Sir, we are live now.
Okay.
I will just
Can I have the slides, please? Yeah.
Yeah. Are the slides visible? Hello?
Yeah. Hello?
Are the slides visible to you?
No, not it. Not it.
Sir, I have already shared it.
Not it. I'm just getting the old slides only. So did you receive my PowerPoint, isn't it?
Yes, sir, I have received your PowerPoint. And
I got it. Yeah, it's there.
Sir,
It is
just
there.
one request. Whenever you are completing with the one slide, no,
Shall I start?
just tell me to change the slide. So I will change it accordingly.
Hello?
Hello?
Hello? Yeah, I'm not hearing you. Hello?
Hello, sir. Just one request. Whenever you are completed with one slide, no, you just tell me to change the slide.
No, I'm not able to hear you, sir.
Hello?
Yeah, no, okay. Some kind of reverberation is there.
Yeah. You just tell me to change the slide once you are done.
Yeah, done. Okay. Shall I start?
Yes, sir, you can.
Yeah, okay. Yeah, good evening, friends. Yeah. For next 30 minutes, probably we'll be discussing about a new concept in gastroenterology. We call that gastroparesis. What is gastroparesis? Gastroparesis is the inability of the stomach to contract. Literal meaning is stomach is not contracting as per it has to be. So next slide, please. Next slide change. Yeah. Gastroparesis is defined as a chronic disorder where there is a delayed gastric emptying in the absence of a structural obstruction. So there is no structural obstruction like a tumor, ulcer or something, but still the gastric emptying is being delayed. How will we calculate gastric emptying? We come to that little later. We have a scintigram that shows us exactly what is the time that is required for the gastric residue to get emptied into the small bowel. Okay. The three primary causes of gastroparesis are diabetic, post-surgical, and idiopathic. These comprises of about 90% of all causes of gastroparesis. Diabetic, post-surgical, idiopathic. Next slide, please. Next slide. So I want slide change, sir, please.
Hello?
Hello?
Hello, yes, I have changed the slides.
Hello?
Hello?
Hello? Yeah.
Yes, sir, I have changed the slide.
Somebody has to change the slide, sir.
I have changed
Somebody
it.
has to change. Yeah, okay. Only now it is visible here. Okay. So this kind of gastroparesis comes under functional gastrointestinal disorder, which is being defined by the Rome criteria, Rome 1, 2, 3, and 4. And this functional gastrointestinal disorder under stomach comes under the gastroduodenal disorder. We call them under two headings. Main heading called as functional dyspepsia, where we have two kinds of things called as postprandial distress syndrome and epigastric pain syndrome. Both of the component will be present in gastroparesis. So this is how Rome defines gastroparesis. We also have other symptoms, related symptoms like belching disorders, which will be excessive supragastric belching or gastric belching, nausea and vomiting disorder, including cyclic vomiting syndrome and rumination syndrome. Next slide, please. So this is the gastric anatomy. Most of people will be knowing that this gastric motility. So once the food enters the stomach, what happens is the fundal part relaxes. The relaxation of the fundal part is aided by the serotonin receptors present in the fundus. It thereby increasing the volume of the stomach, so that the stomach can have more and more of the food. So most of the food stay in the fundal part of the stomach. Okay, whereby small quantity of quantity of the food get trickled down into the antrum, where the antrum contraction happens, and it goes to the lower part of antrum, where it has the antral peristalsis, which is more circumscribable than it is longitudinal, and thereby enters the pylorus. The pylorus, usually the antroduodenal pylorus mechanism is called as mill. We call them just like a mixer grinder. This mill pulverizes the food material into smaller and smaller parts into some kind of mashed kind of food material, whereby it enters the duodenum. This is the mechanism of digestion happening in the stomach. Okay, so there is a fundal relaxation which accommodates the food particle, and some of the food particles trickling down will be milled by the antrum, and the antropyloric mechanism pulverizes the food material which enters into the duodenum. Next slide, please. Yeah, next slide. Yeah. How this happens? It happens because of the neural mechanism. They got the lower esophageal sphincter, which guards the entrance to the stomach, and after that there is a pacemaker, which is there in the upper part of the body of the stomach along the greater curvature. This is called as the pacemaker of the stomach, where the most of the impulses or electrical impulses in the stomach starts. It has two directions. One is a longitudinal direction towards the pylorus, and another will be a circular direction which constricts the entire stomach, and also it propagates in the longitudinal direction. Okay, so there is a migrating motor complex, basic electrical potential in the stomach, which is of almost about 3 CPM, 3 contraction per minute, which is recorded in the resting stage. And once there is a feed, the stomach goes to contraction, which is called as a fed state, when there is a slow wave and there is a fast wave. Both of them will be alternating, and it is triggered by the pacemaker region. Next slide, please. This is the neuromuscular connections happening in the microscopic level in this stomach. The uppermost layer is called as smooth muscle fibers, smooth muscle cells, which is in close contact with the interstitial cell of Cajal. The interstitial cell of Cajal is the lowermost representation of the central nervous system, happens in the myenteric plexus of the stomach. Okay, below that is the muscle cells, the smooth muscle cells of the stomach. Okay, so there is a lot of neurotransmitters happening across these cells. Interstitial Cajal, cells of Cajal secretes a lot of neurotransmitters, which either relaxes or contracts the smooth muscle cells of the stomach. Okay, the neural output will be coming from in terms of acetylcholine or PDGRF or 5-hydroxytryptamine or dopamine also. So these neurotransmitters alter the contraction and relaxation of the stomach, thereby forming a propulsive movement which drives the food particles into the into the duodenum. Okay, when there is a fault in the neuromuscular connections, or when the neurotransmitters are at the fault, there will be significant gastroparesis happening in the stomach. Next slide, please. So what are the causes of gastroparesis? As we told, the main 3 causes of gastroparesis are idiopathic, secondary to diabetes mellitus, long-term diabetes mellitus because of the introneuropathies, and third is a post-surgical. Apart from that, other causes like infections, cytomegaloviruses, Epstein-Barr viruses, varicella, Novak, rotaviruses, Trypanosoma cruzi in the African subcontinent, all are common causes of gastroparesis. Next slide, please. Medications which we commonly use like opioids, Cannabinoids, alpha agonists like clonidine, tricyclic antidepressants, calcium channel blockers, lithium octreotide, which is commonly used in other gastrointestinal disorders, GLP, glucagon-like peptides, like in use for diabetes mellitus, phenothiazines, cyclosporins, PPIs, nicotine, progesterone, all can cause significant amount of gastroparesis when used for longer periods of time. Next slide, please. Most of them are reversible. While stopping the drug, we get back the normal contraction. Some of them may not be reversible. Post-surgical surgeries like gastrectomies, Roux-en-Y surgeries, Billroth type 2 surgeries, fundoplications, bariatric surgeries where we do a sleeve gastrectomy, etc., pancreatic surgeries, and heart and lung transplants, all of them involve in cutting the nerves along the stomach, and these conditions we get gastroparesis. Some of the post-surgical gastroparesis are reversible, but many of them may not be reversible. Next slide, please. These are some of the other causes of gastroparesis, rarer causes of gastroparesis. One is the connective tissue disorders like systemic sclerosis, mixed connective tissue disorders, polymyositis, Ehlers-Danlos syndromes, demyelinating diseases like multiple sclerosis, myotonia dystrophica, paraneoplastic presentations of small cell carcinoma, lung, pancreatic cancer, cholangiocarcinoma, leiomyosarcoma, lymphomas, other functional dyspepsias, autoimmune disorders like myasthenia, Sjogren's disease, Parkinsonism, vitamin B12 deficiency, porphyria, hypothyroidism is another cause of gastroparesis, renal failure, people on dialysis which have neuropathies, amyloidosis which affects the nerves also can cause gastroparesis, mesenteric ischemia, GERD, celiac plexus injury or compression because of other tumors, etc. Eosinophilic gastroenteritis, mastocytosis, cystic fibrosis, all may mimic as gastroparesis, and the treatment of individual things will be depending on the underlying cause and the treatment options. Next slide, please. What are the symptoms of gastroparesis? Next slide. Yeah. What are the symptoms of gastroparesis? Predominantly the previous one. Yeah, correct. Yeah. So predominantly the patients will have nausea, vomiting, abdominal fullness. Post-prandial distress is a classical symptom of gastroparesis. People have early satiety and fullness after a small quantity of food intake. Abdominal effort to reduce the bloating. People also may have weight loss, loss of appetite, loss of sleep, irritability, mood swings, etc. Next slide, please. When seeing these patients, we can note the patients will be dehydrated, will have nutrition deficiency in the form of protein, energy, malnutrition, vitamin deficiencies, etc. Evidence of diabetic atomic.
Hello. Sir, sorry to interrupt, but you are not audible.
Since when?
You are not audible, sir. Yeah, now it is audible.
Okay, am I audible?
Yes, now you are audible.
Okay. Yeah. So patient may have evidence of dehydration, evidence of diabetic autonomic dysfunction like partial hypotension, tingling and numbness over the past, and loss of sensation, etc. All can happen. And features of systemic sclerosis or other connective tissue disorders may be evident. CT and MRI should be ruled out, should be done to rule out any kind of obstructions. And UG endoscopies usually will have food stasis and erosive esophagitis, etc., without any obstructive findings like ulcer or growth in the stomach. Next slide. This is a scale that we use during research or publications to generalize or to categorize the amount of discomfort they feel while 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 screening a large amount of population. Okay, this scale is called as Gastroparesis Cardinal Symptom Index. It takes into account of the following symptoms like nausea, feeling sick on your stomach, and retching, vomiting, stomach fullness, not able to finish a normal sized meal, feeling excessively full after meals, loss of appetite, bloating, and stomach or belly is larger after a food meal. These are symptoms that are self noticeable, and people can just fill out a form and give it to the doctor so that they can have a collective information on how things are. Okay, we can also
Sir, you're on mute. Sorry to interrupt, sir. You're on mute. Hello? Sir, you're on mute.
hello.
Yes, sir. Now you're audible.
Hello.
Hello? Yes, sir. You're audible now.
Yeah. Okay. Next slide, please. Okay. This is the anterodiurnal manometry, which we used to perform for gastroparesis and for other disorders. We plot the stomach contraction with respect to the pH, okay, the intragastric pH. After a fed state, the pH rises and the stomach contraction also rises. This gives a correlation between the gastric acid pH and the stomach contraction over the pylorus. Next slide, please. This is how we work for gastroparesis, the workup pattern in gastroparesis. We confirm gastroparesis by history, physical examination, and medication review. We do a laboratory workup to rule out other comorbidities, paraneoplastic pictures, mimickers, etc. We ask the patient to give a complete blood counts, electrolytes, sodium, potassium, magnesium, calcium, etc. ESR, thyroid function test, HbA1c to detect any long-term uncontrolled diabetic mellitus, vitamin B12, vitamin D, and ANA. This is for a basic screening for autoimmune disorders. We do an upper GI endoscopy to rule out ulcer or other mechanical obstruction, and we proceed with the gastric emptying scintigraphy. The scintigraphy is normal. We consider other diagnoses other than gastroparesis, like functional dyspepsia, postprandial distress syndrome, etc. And if it is delayed more than 4 hours, we call them gastroparesis. Next slide, please. This is the gastric scintigram. The first pattern, the pattern A is normal. We give a meal and repeatedly we scan them every 30 minutes. And first 0, 30, 60, 120, 180, and 240. For 4 hours, we do a repeat scintigraph. Okay. The meal will contain a little bit of radioactive material so that we can just get a glimpse of it during the scintigram. Normal pattern is almost 80% of the food will delivered into the duodenum by the end of 3 hours and 90% by the end of 4 hours. Okay, this is normal. Gastroparesis is diagnosed when more than 50% of meal is present beyond 4 hours, beyond 240 minutes. The pattern B detects that there is amount of food material which is dark black that is present inside the stomach even after 4 hours. This is gastroparesis. Okay. The retention of more than 50% after 4 hours, we call them gastroparesis, and we grade them in grade 1, 2, and 3. Next slide, please. This is a modern gastric scintigram where we have a colorful image that can relate to the food in the stomach. At the initial stages, the food will be present predominantly in the fundus. As I told you, there's a fundus relaxation, and food is accommodated into the fundus. Slowly it trickles down to the antrum. After 30 minutes, it's present predominantly in the antrum and the pylorus. 60 minutes, it is still present in the stomach. 120 minutes, slowly the movement of the food particle is detected in the duodenum also. By 240 minutes, almost all the food will be emptied into the duodenum. This is normal finding. Next slide, please. According to the severity of the scintigram finding, we can say that there is a mild, moderate, severe, and very severe gastroparesis happening in the individual. Okay, if the percentage of meal remaining after 4 hours is 20%, 11 to 20%, we call them mild. When it is 20 to 35%, we call them moderate, and when it is up to 50%, we call them severe, and it is beyond 50%, we call them very, very severe. Next slide, please. Yeah, this is wireless motility testing. We can use a wireless capsule within the stomach to find out the stomach contraction, which is related to the pH. This also can be used to diagnose gastroparesis, although it is very difficult to interpret the findings. It can be very handful in patients who have dysarrhythmia. Dysarrhythmia is the motility of the stomach is disorganized and dysynchronized. This is called as gastric dysarrhythmia. This can be diagnosed with wireless motility testing. Patient has to swallow a capsule and the recordings will be taken wirelessly in a computer. Okay, next slide, please. So DD of gastroparesis are the rumination syndrome, function dyspepsia, where there is no gastroparesis, but patient may have fullness in the abdomen. Cyclical vomiting syndrome, patient may have repeated vomiting without any gastroparesis. Next slide, please. These are other differential diagnosis that also has to be considered in the mind before claiming it is gastroparesis. They are mechanical GI obstruction like pyloric obstruction, bile duct obstruction, small intestinal colon. Sometimes the bile duct obstruction, that is cholangiocarcinoma or periampullary tumor, sometimes may not be evident by the upper GI endoscopy because it may be well beyond D2. So we have to go till D2 and D3 and rule out any mechanical obstruction to the food flow into the small intestine. Sometimes small intestinal cancer also can present as gastroparesis. Only after careful observation and CT scan, we can detect small intestinal cancer. Mucosal inflammation like allergic gastroenteritis or eosinophilic gastroenteritis also can present as gastroparesis. Peritoneal irritations, carcinomas like gastric, ovarian, bronchogenic carcinomas, endocrine disorders, as we already told, hypothyroidism, diabetes mellitus, etc. Medication, we already reviewed the medications. Gastric dysarrhythmias, tachygastria and bradygastria. When the contractions are high, we call them tachygastria. When the contractions are low, we call them bradygastria. And maybe there will be mixed patterns also. CNS disorders like frontal tumors, migraine, seizures also can cause cyclical vomiting and gastroparesis. Also some kind of psychological disorders like anorexia, bulimia, and the patient voluntarily vomits and they claim that it could be gastroparesis. Next slide, please. So these things should be carefully thought of and eliminated. So coming to the gastric scintigram, with the gastric scintigram and wireless motility testing, we come to four categories of this gastroparesis. Okay. First category, when the gastric arrhythmia or gastric contractions are smooth and normal, synchronized, and there is gastroparesis, but the contractions are not strong enough to have a contraction. The electrical stimulus or electrical pattern is normal. They have no good synchronization. There is no abnormality, no tachygastria or bradygastria, but still the electrical stimulation is not adequate enough to start a contraction. This is called as category 1. Okay, this is gastric dysarrhythmia and gastroparesis. Okay, the second group is what I told, normal gastric electrical stimulation, but there is significant amount of gastroparesis. Third category, there is a significant gastric dysarrhythmia, either tachy or bradygastria or mixed type, with normal emptying. There is no food residue in the stomach, and beyond 4 hours, there is no food residue happening in the stomach. Okay, this is gastric dysarrhythmia, pure gastric dysarrhythmia. And the fourth pattern is normal gastric rhythm and normal emptying. This is almost normal, but the patient may feel fullness in the stomach. This is functional dyspepsia. Okay, 4 categories. One is the patient has abnormal electrical rhythm and gastroparesis, category 1. Second is normal gastric rhythm and gastroparesis. Third is abnormal gastric rhythm and normal emptying. And fourth is rhythm is normal, there is normal emptying, and the patient feels fullness. This is functional dyspepsia, postprandial distress syndrome. Okay. Next slide, please. So, how do we treat these patients? Category 1 patients, and there is a gastric dysarrhythmia and gastroparesis. A diagnosis done by severe gastric myoelectrical contractile disorder, uh, diagnosed by gastric scintigram as well as gastroparesis. The treatment is nausea and vomiting diet, which will come to a little later. Prokinetic therapy will be used for these patients. Anti-nauseating therapies, gastrectomy or tube jejunostomy, total parenteral nutrition in severe cases, acute stimulation that we come to a little later. Endoscopic therapies like gastric poem that also we'll mention in the towards the end, and gastric electrical stimulation and gastric pacemaker. These are the armamentarium by which we treat a combined disorder of gastric dysarrhythmia as well as gastroparesis. Okay, when there is a normal rhythm and gastroparesis, we use Botox. Okay, Botox is used only if the rhythm is normal. Botox or surgery for obstruction like antrectomy, etc. Nausea and vomiting diet, prokinetic therapy, and anti-nausea therapy may be adjuvant. Okay. For people with severe dysarrhythmia but normal emptying, we usually give a nausea and anti-vomiting diet, prokinetic and anti-nauseating therapy. So when the person have functional dyspepsia without any rhythm abnormality or contraction abnormality, we put them on nausea and vomiting diet, antidepressants, and prokinetics also can be used. Functional workup for atypical GERD, cholecystitis, irritable bowel syndrome, or disorders of central or autonomous nervous system should be undertaken as per requirement. Next slide, please. These are some of the medications that we have in our armamentarium. One is erythromycin, time tested. This is a motility receptor antagonist, which is used in the dose of 125 to 250 milligram 3 to 4 times a day, which is anti-nauseant and is a prokinetic. Okay. Other prokinetic drugs include metoclopramide, domperidone, cisapride, tegopride, etc. Cisapride has gone into disfavor because of the abnormality QT interval cardiac dysarrhythmia, so it is no longer used. Tegopride, previously used as a prokinetic, was also banned because of risk of ischemic colitis in elderly ladies. These prokinetic drugs act by a common mechanism, the 5-hydroxytryptamine. They antagonize 5-hydroxy 3 and agonist of 5-hydroxy 4. Okay. Second group of drugs are the ghrelin antagonists like Rilamorelin, which is not available in India, which has anti-diabetic activity as well as the membrane stabilizing activity. Can be given for diabetic gastroparesis. Next group of drugs are the pro-relaxant drugs like dicyclomine, bispirone, or botulinum toxins. They decrease the gastric stimulation. This is used for gastric tachyarrhythmias and dysarrhythmias, and these are predominantly 5-HT3/1 agonist or a muscarinic antagonist, and used before meals 10 to 20 milligram, which reduces the pain and gastric contraction associated with meal. Okay, can cause drowsiness and dry mouth. Next slide, please. Next group of drugs are the serotonin antagonists like ondansetron, granisetron, etc. They are 5-HT3 antagonists, can be used to prevent nausea. This is an anti-nauseating agents. They're used by a central mechanism. Okay. Phenothiazines also are anti-nauseating. Prochlorperazine can be used. Antihistamines like promethazine, dimenhydrinate, cyclizine, all can be anti-nauseating, can be used for nausea. These are H2-1 receptor antagonists. Butyrophenones like droperidol can be used as a central dopaminergic antagonist, can reduce the centrally triggered nausea and vomiting. Antidepressant like amitriptyline, nortriptyline, visatriptyline. Next slide, please. Before, sorry, one slide before. Two slides previously. Just go back. Yeah. Okay. Antidepressants like amitriptyline, nortriptyline, mirsatriptyline, and benzodiazepine agents like lorazepam, alprazolam, all can be used that reduces the nausea. Next slide. Yeah. Newer drugs like apripilat is a newer drug that acts on the substance P antagonist. This can reduce the hiccups and the postprandial fullness. Therapies like non-pharmacological therapies like acupressure, acupuncture, etc. can reduce the stimulation of the stomach and can be used to reduce the gastric dysarrhythmias. The effect will be variable, but still some people may benefit from it. Gastric efferent stimulation with the electrode or something can be tried in these patients. And gastric pacing has now been approved by the FDA to control dysarrhythmic forms of gastroparesis. Endoscopic therapies like Botox injection into the pylorus can relax the pyloric muscle, can be used for gastric dysarrhythmia associated with gastroparesis. Okay, balloon dilatation of pylorus, G-poem also can be done. That relaxes the pylorus muscle and can relieve the gastroparesis. Radiofrequency ablation of LES also can be done for these patients because they are sometimes combined with achalasia cardia also. Diet therapies like gastroparesis diet, high protein drinks, gastrectomy, jejunostomy, and TPN can be done for refractory cases when the patient continues to have vomiting and nausea despite any amount of medicines. Next slide. Next slide. And this is G-poem. What we do, we just target the pylorus of the stomach and just near the pyloric ring, we just put a small incision in the musculus mucosa. We elevate the musculus mucosa and go to the submucosa, and we just resect some amount of submucosa so that the pylorus will dilate, relax. Because of the pyloric relaxation, there will not be food stays in the stomach. So gastroparesis will be ameliorated by G-poem. This is called as gastric poem. This is exactly what we do for achalasia cardia in the esophageal-gastric junction. Next slide, please. Gastric electric stimulation has come a long way. It has been approved by the FDA recently, used for diabetic and idiopathic gastroparesis. In that, high frequency, low energy stimulation is applied to the musculus mucosa propria through electrodes present in the underneath the skin. This can give a continuous stimulation or stimulation whenever necessary, postprandial stimulation, etc. We can teach the patient to induce electrical stimulation post meal or post distress. So this can be done. Next slide, please. This is how the flow chart for treating. We start them with the prokinetics. When there is a clinical response, we continue and maintain the low effective dose. When there is no relief with metoclopramide, we sequentially change the prokinetic till the patient has some amount of symptoms like 5-HT3/4 antagonists, newer drugs, etc., antiemetics and anti-nauseants and pain modulators. Still, there is no improvement. We can try with gastric stimulators like electrical stimulation or G-poem, or surgery or pyloroplasty, etc. Despite that, even the patient has severe symptoms after endoscopic therapy, we consider them for feeding jejunostomy or decompressive gastrostomy. Next slide, please. This is a feeding pattern for people with severe nausea and vomiting, severe gastroparesis. The first day, we give them for the patient with severe nausea and vomiting, small volumes of salty liquids. We start with small volume of salty liquids, 1000 ml per day in multiple servings, that is 100 ml each serving over 12 to 14 hours. Patient can sip about 30 to 50 ml each time to reach 120 ml per hour. This is the first day diet. And if this is tolerated, we can start on soups and smoothies. Soups like mashed diet or mashed kanjis, porridge, etc. can be used. Peanut butter, cheese can be used. Caramels or ice creams can be used, which gives some amount of calories and some amount of fluid also. Okay, just avoid volume depletion by giving intravenous fluids also. Step 3, if this is tolerated, we can start them on bland starches like boiled rice, kanji, and something like that. Chicken or fish broth can be given, and when there is mashed chicken or meat can be given, or some amount of mashed vegetables can be given on the third day or the fourth day. When this is being tolerated, we can switch over to soft diet or semi-solid diet. This is the pattern of refeeding these patients who have severe nausea and vomiting. Next slide, please. When they don't tolerate even small quantity of liquids, we can switch over to nasogastric tubing or nasodeginal or nasoduodenal tubing. Nasogastric tube can be used temporarily to decompress the gastric content. Nasodeginal tube can be used for feeding. Gastrostomy can be used for venting when there is a gastric fullness and the patient is unable to take furthermore diet. We can just have a venting tube so that once the patient feels discomfort after taking food, they can vent out some amount of food in the stomach. This is called as venting tube. Percutaneous endoscopic gastrostomy or jejunostomy can be done under endoscopy or fluoroscopic guidance that can directly feed the patients from the duodenum or jejunal end so that nutrition will be balanced. Jejunostomy tube can be done by laparoscopic methods, or dual gastrostomy and jejunostomy tube can be used both for feeding as well as venting purposes. They can be used for refractory patients who have chronic gastroparesis and on home care or something like that. Next slide, please. Yeah, thank you for patient listening. And I hope there is some doubts or something. I'll be happy to spend another 5 minutes on that.
Hello. Yeah, sir.
Hello.
There are questions also now. So I'll be taking one by one question. Okay.
Yeah.
So the first question is, hello?
Yeah.
Yes, sir. The first question is there any evidence to support the use of certain probiotics in the management of congenital gastroparesis?
No, probiotics will not help in gastroparesis because gastroparesis, especially congenital gastroparesis, occurs because of the abnormality in the formation of the myenteric plexus and mesenteric plexus. So probiotics may not be of use. You're asking about prokinetics or probiotics?
Probiotics.
Probiotic, no role for probiotics.
So the second question is, what are your comments on managing gastroparesis after renal transplant?
This occurs because of the diabetic neuropathy the patient has. Commonest cause of renal failure in India is diabetes mellitus. And the post-renal transplant people have gastroparesis secondary to diabetic neuropathy and gastroparesis because of neuropathy. Okay, this can be managed as per neuropathic gastroparesis of any other cause. We start with prokinetics. If it is not working, we have some newer drugs that can be used for these gastroparesis patients.
Yes, sir. We are done with all the questions now. And thank you very much, sir, for your valuable
Thank you very
time
much.
and support.
Thank you.
Which you are
I will
giving.
meet next month.
Yes.
Yeah. Thank
Yeah,
you.
sir. Sure,
Thank
sir.
you.
Thank you very much.
Bye. Bye.
Bye, sir.